Good morning, everyone. Thank you so much for joining us this morning. Today, we have the privilege of having Dr. Tomek Piorkowski, who is a hematopathologist at Pathcare laboratories. He qualified in laboratory hematology in 2023 and briefly worked at the South African National Blood Service before joining Pathcare. So prior to specializing, he practiced as a general practitioner in various primary healthcare settings and served as a part-time lecturer at the University of Pretoria. His professional interests include consultative hematology, laboratory quality improvement, and morphological assessment. Thank you so much for presenting today. I'll just hand over to you. Thank you.
And he's also a writer.
Ooh.
Yes, thank you for the kind introduction. Just a reminder for people online to please put your name and MP number and email in the chat box for your CPD point. Right, so my topic today, it's three little topics, but they're all sort of work well together. I'm going to discuss briefly blood groups. Then we're going to discuss mass transfusion, and it works well because to properly understand mass transfusion, you need to have the basic knowledge of blood groups. And then we're going to go to thromboelastography, which is a method to monitor mass transfusion. So all these topics are giving them separately, but they are interrelated. So those are topics I'm covering. So going straight into the blood groups, there are about 30 different blood groups. But in terms of the ones that clinicians should be aware of because they are the most clinically relevant, you want to know the ABO blood group, the rhesus blood group, KEL, Duffy, and KIT. I think as a clinician, if you know these blood groups, you already know 90% of the blood groups that are going to give you 90% plus of all the blood groups that will give you issues in clinical practice. So we start with ABO. It is technically a tissue type. So it's not just red cells that have this ABO, these ABO antigens. So some textbooks refer to it as a histo blood group or tissue blood group. It is not unique to humans. It's commonly expressed by many organisms. And they are carbohydrate molecules that are expressed on the cell surface. And that's relevant because carbohydrate antigens tend to stimulate IgM antibodies. So the A and B antigens are formed from the H antigen. So what happens is you have a precursor substance on your cell membrane. Most human beings have an H gene, which causes this precursor substance to be transformed into antigen H. And if you only have antigen H, you are blood group O. If you have the A gene or the B gene, you'll then convert this H substance into an A or B. And if you have both genes, you'll have AB. You do have rare subtypes, such as the H null, the Bombay blood group. So these are people that have precursor substance and are unable to change that precursor substance to blood group H. So that's called the Bombay blood type, and there are various other blood subtypes such as weak A. The physiological function of the ABO blood group is unknown, and you develop IgM antibodies at around 6 months of age. The exact mechanism is not known, but it's hypothesized that when you are exposed to gut bacteria and to plant material that has ABO antigens, that stimulates antibody formation against any antigen that is not recognized as inborn. So in other words, if you're blood group B, you will form antibodies against antigen A. If you're blood group O, you can also occasionally form IgG, which is unusual because carbohydrates should generally stimulate IgM formation. But blood group O people can also form IgG antibodies against A or B, and that is relevant for ABO incompatibility and a hemolytic disease of the newborn, where IgG antibodies can cross the placenta. IgM fixes complement, and by fixing complement, they can cause acute hemolytic transfusion reactions. So that is by this reaction is by far the most deadly reaction in blood transfusion medicine. And just to dive into more deeply as to what happens with ABO incompatibility, you have your IgM antibodies would then bind to the transfused red cells, and this causes sort of inflammatory cascade. You have complement activation, which creates membrane attack complexes, which causes intravascular hemolysis with the release of hemoglobin dimers and heme. These then overwhelm the kidney, which can then cause acute renal failure and acute tubular necrosis. They also stimulate, the activated complement also stimulates inflammatory pathways of stimulation and activation of your immune system cells with the release of cytokines and chemokines, with the result that you get fever, DIC, and vasodilation. You can also have stimulation of histaminergic pathways. So sometimes acute hemolytic transfusion reaction will present with symptoms that might confuse you for an allergic reaction, such as urticaria rash and bronchospasm. So generally, the patients die due to DIC and to renal failure. You need about 5 mL of transfused blood to cause an acute hemolytic transfusion reaction. So 5 mL of an incompatible blood transfusion is sufficient to land a patient in ICU with poor outcomes. So as I mentioned, it's the most immediately deadly complication. And this is the first problem that you have to solve in order to safely transfuse a patient. Blood transfusion can only become a reality once this ABO incompatibility problem was solved. So imagine that you are in a deeply rural hospital in a very poor country, and you don't have access to blood transfusion service, but you are dealing with a lot of PPHs perhaps, and you have lots of willing donors, and you want to try and transfuse some of your patients to reduce the risk of PPH. So what you do is you take your blood samples from your patient and your potential donor, and you use this very advanced technology to spin your sample down to separate the red blood cells and the serum. No, wait, yes, so you got your plasma here with all the antibodies and your red cells. You pull up the patient's plasma, and you take the red cells from the donor. You take a plate from your tea room. You put a drop of the patient's plasma and the donor's blood on your plate, mix them together. And if they are not compatible, those IgM antibodies are going to cause red cells to clump, so cause agglutination. So then you know that this donor and patient are not compatible. There is an ABO incompatibility there. Otherwise, if you don't see the agglutination, you will you know that there shouldn't be ABO incompatibility. So there might be other things. There might be HIV, there might be syphilis, there might be things that cause delayed hemolytic reactions or delayed issues, but you're avoiding the most deadly complication, which is the acute hemolytic reaction. So then you put your donor on a bed and your patient on the floor, connect the two, wait until your donor is pale and tachycardic and your patient is nice and pink, and then you have done a blood transfusion. All right. So once the ABO issue was solved, the next sort of antigens that were discovered to start giving issues were things like rhesus. We know anti-D or D rhesus is the famous one, but you also have a big C, little c, big E, little e, and there's a couple more, but these are the most clinically relevant. It is a very large protein that moves multiple times in and out of the cell. So this is rhesus in comparison to your ABOs, your Duffy, and your KIT antigen. So the rhesus is quite big with many points where you can develop anti-rhesus antibodies. And the reason I mention that is that sometimes you get a mutation where you lose only part of the protein. And then with antigen testing, our antigen test might, for example, bind to these two loops and say this patient's RHD positive, but the patient's missing perhaps half the whole rhesus molecule. And then the patient can develop anti-D antibodies, even though they're supposedly Rh positive. And this is a condition called partial D, which depending on the population can affect 0.1 to 1% of your female population. So that's why in Western settings, they're moving away from antigen typing to genetic typing of the D status in order to protect that small percentage of women who taste false positive for RHD. The rhesus protein helps to maintain your cell membrane integrity. You do get people who are Rh null. They don't have any Rh proteins on their cell membrane, and they have a shortened red cell lifespan, and may even have a chronic anemia and have abnormal red cell morphology. It is a protein, so when you do form antibodies against, it tends to be IgG, and that can be from a mismatched blood transfusion or fetal blood exposure. Once you have these antibodies, the main issue that is associated with hemolytic disease of the newborn, which can be quite severe, and it can also get delayed hemolytic transfusion reactions, which are usually mild. So generally, with rhesus matching, you're more worried about your females of childbearing potential. They should be matched to at least D. More advanced settings are now matching to C and E as well. And if your patient's chronically transfused, you should ask the SAMBUS to do an extended Rh phenotype for your patient and to match to the full profile in order to reduce the risk of alloantibodies and delayed hemolytic transfusion reactions over the long term. So when is Rh important? So if you have transfusion naive patient, you're not going to have those IgG antibodies. You're not going to have an immediately life-threatening thing from doing an Rh incompatible transfusion. The main issue is to avoid hemolytic disease of the newborn, so you should prioritize giving Rh negative blood to Rh negative women of childbearing potential. So basically any woman between 5 and 55. So they should be prioritized to receive Rh negative blood. If you do give them RHD positive blood, you're going to need 15,000 international units of anti-D to neutralize that incompatibility, which is not realistic in South Africa, because in South Africa, this is what we have. We have a 500 international unit IMI injection. So you need about 30 of these IMI to neutralize 1 unit of incompatible red cells. Other countries have IVI formulations with very high doses, so it's more realistic in the well-resourced setting where you have that formulation available. So in our setting, we should just try and avoid it as much as possible. If you do give a D-incompatible transfusion to a man or to a woman of childbearing potential, that is not a big issue. They will develop antibodies later, and often they do not develop antibodies. I think, if I remember correctly, in the acute setting, only about 20% of patients develop anti-D antibodies if they are given a Rh incompatible transfusion. It's more important in the transfusion-dependent patient where you want to do extended Rh phenotype matching, which you can request from SAMBUS. In an emergency situation, if you have a fridge and it's got some O positive emergency blood and O negative blood, you should avoid the use of the O negative blood for your males. And if you're and for the females without childbearing potential, which in this graph is the woman above 50 years of age. Rather, give them the O positive blood in an emergency situation. You want to save your O negative blood for females of childbearing potential. Next antigen is CAL, which is a small protein. It's a protein, so it tends to generate IgG. It's predominant in erythroid precursor cells rather than the mature red cells. So it tends to interfere with red cell maturation rather than hemolyzing the mature red cells. There are multiple types of CAL, and these are the sort of 6 most clinically relevant forms. And because it's a protein, it tends to form IgG, but unusually, CAL can also form IgM. It's the third most immunogenic blood antigen after ABO and RH, can cause very severe fetal anemia through the destruction of erythroid precursors, the so-called bone marrow hemolysis. It's an important cause of hemolytic transfusion reactions, especially in the chronically transfused. And because it occasionally makes IgM antibodies, it can sometimes cause severe hemolytic transfusion reactions. Patients who are chronically transfused should actually have to be matched to the CAL phenotype in order to avoid this potential severe complication. And that is a service offered by SANBS. So you can ask SANBS to please do extended phenotype for rhesus and CAL to provide units matched to that phenotype. Next blood group is KID, which is a large protein. It's involved in urea transport in and out of cells. It's expressed on red cells and kidney cells. It doesn't seem to have to be necessary for the red cell function. So you do get KID null patients, and there's no overt effect on their health. They make IgG antibodies, but unusually these IgG antibodies can fix complement. So it's a subset of IgG that fixes complement, just like IgM. That said, so it will cause a delayed hemolytic transfusion reaction, but because of this complement fixation, it can be quite severe and cross the placenta, and usually causes mild hemolytic newborn. Because of complement fixation, it can also rarely cause acute hemolytic transfusion reaction. So in very well-resourced settings, chronically transfused patients are checked for the KID phenotype to avoid that rare complication. Then you've got Duffy. It's a moderate-sized protein. It binds to chemokines. It recruits neutrophils into the bloodstream. It also helps Plasmodium vivax to invade the red cell. And so in the malaria belt, due to sort of evolutionary pressure, you have up to 100% of patients being Duffy null in the high malaria zones. What is the sort of clinical effect of that? It doesn't seem to have any adverse effect except that it causes benign ethnic neutropenia. Remember, Duffy recruits neutrophils into the bloodstream. If you don't have Duffy, you don't have as high a circulating number of neutrophils. That's not to say they have a true neutropenia. Actually, these neutrophils in Duffy negative patients have been marginated. They're rolling along the blood vessel wall, or they're in the tissue. So when you take a blood sample from the middle of the blood vessel, you're missing all those neutrophils that would normally have been recruited into the bloodstream because of Duffy. So they have what's called a benign ethnic neutropenia, which is due to being Duffy null. And sometimes if you have a patient with chronic neutropenia, you suspect that this might be benign ethnic neutropenia, you can ask SANBS to test the Duffy status. And if they are Duffy negative, you have confirmed the diagnosis. Being a protein, they predominantly make IgG antibodies, and they're associated with hemolytic disease of the newborn, and they can cause delayed hemolytic transfusion reaction. And because of this, in well-resourced settings, they provide Duffy-matched products, especially for your high-risk patients who are from that malaria risk belt. So the take-home messages in terms of blood groups, we need to avoid ABO mismatch. So when I was at SANBS, the things that caused ABO mismatch were often pre-blood bank, as doctors were in a rush. They took details from a file and rather than from the patient. They were trying to do multiple samples at a time. So do one sample at a time. Make sure that you're checking the patient's identity, not the identity of the file. Make sure the forms are filled in correctly. Preserve the emergency ONEG stocks rather for emergencies, rather give O-pos blood to men and non-fertile women. Then you can you're going to go into massive transfusion now, so we can generate allo antibodies such as anti-Duffy and anti-KID. So to be aware that those things can be generated, but it's a secondary concern in the emergency transfusion setting. If you have a chronically transfused patient, up to 30% will develop allo antibodies, and 60% of these will be against the big C, little c, big E, little e, or CAL. And the rest of them will be KID and Duffy. But these tend to cause the most clinically significant symptoms. And if you have a patient who you are transfusing every month, every 2 months, they deserve extended phenotyping for the RH group and KEL. That is a service offered by SANBUS, and once they've phenotyped, you can ask SANBUS to provide RH and KEL matched products. And then in more well-resourced settings, they're going on to also phenotype for KID and Duffy. And now we're going to discuss massive transfusion, and there are a couple of controversies and issues, what I call the sticky points of massive transfusion. First of all, transfusion protocols vary greatly, and there's no protocol that's proven better than any other. And a lot of it depends on what your local blood bank is actually capable of. So as a clinician, you might read a nice article about this nice transfusion protocol, and you then might insist that this is what you want to implement in your setting. But you should first check with your local blood bank whether that protocol itself is realistic in terms of what they can provide as a service to your hospital. Blood products are also not equivalent across transfusion services, in particular with regards to platelets, and this is often not really discussed in the literature on massive transfusion. I think because clinicians tend not to work in the blood bank, they assume that a platelet product from the US is equivalent to a platelet product from the UK, equivalent to a platelet product from South Africa. Now, most Western blood services make a pooled platelet product from 4 donors. This is particularly true in Europe, and this is what you should bear in mind when you're reading European literature. SANBUS uses 5 donors, and North America tends to use 6. So what do I mean by that? You have a patient donating a unit of whole blood. This is spun down into plasma, the buffy coat, and the red blood cells. The buffy coat is where all the platelets are. We then combined the buffy coats. So this picture is from, I think, the Canadian Blood Service. They follow the European standard of 4 platelet buffy coats. They mix it with some plasma or platelet additive solution and make it a pooled unit. So a pooled platelet unit in Canada and Europe represents 4 platelet donations. So that's for the platelets from 4 different people. In the US, they use 6 donors to pool the platelet. And in South Africa, we are using 5. Ideally, you want to leuko-reduce them to create a leuko-reduced buffy coat. Platelets, because leuko-reduced, because with a buffy coat, you also get a lot of white blood cells, which can cause transfusion reactions, so you ideally need to leuko-reduce. So now when you're reading the literature, you need to ask, when they say it's a 4-4-1 ratio, 4 red cells, 4 plasmas with 1 pooled platelet unit, are they standardizing it to the 4, the 5, or the 6 pooled platelet unit? Because the original rationale of the massive transfusion is that you are sort of giving back 4 donors worth of donations back into the patient. That would be 4 red cells, 4 plasma units, and 4 platelet units that have been pooled. In South Africa, to actually maintain that sort of 1-1-1 ratio in terms of donors, you'd actually technically have to give 5 red cells, 5 plasma, 1 pooled unit of 5 donors. And in the US, technically, you need to give 6-6-1, so 6 red cells, 6 plasma units, and 1 pooled platelet unit from 6 donors. Now, the problem is when you go into literature, platelets are often not very well defined, I think, because the literature is written by clinicians rather than blood bank people that work in the blood bank. And sometimes it's not clear if the clinician authors are referring to a single buffy coat-derived unit and how many donors are in that unit, or if they're referring to apheresis units, which is the equivalent of a multiple sort of donor unit, but taken from 1 patient, and how many units are in the pooled platelet products. Then the other sticky point is what plasma to use. So traditionally, we give AB plasma. Some centers are now using A plasma as well in massive transfusion on the basis that the B the anti-B antibodies present in A plasma are generally very weak, and in a massive transfusion setting are clinically not relevant. That's more expert opinion rather than science. And even doesn't matter in massive transfusion because you're washing so much of the patient's blood out with a transfused blood.
Sorry, again, 650.
Can I ask you to mute your microphone? Where was I? Okay, and then the other issue with SANBUS, I mean, most of these protocols refer to fresh frozen plasma. SANBUS does not make fresh frozen plasma. They make frozen plasma, frozen within 24 hours. Now, the limited literature on frozen plasma within 24 hours in the sort of more elective setting or surgical setting is that this is an equivalent product of fresh frozen plasma. So Sandoz doesn't even label this as FFP24, they just call it FFP. That's what they give into the health service. And the reason for that is because distances are great in South Africa. We are a low density population. Samples have to be transferred to a central processing facility from outlying areas. It's just very difficult and due to the geographic spread and the low density of the South African population and the limited amount of resources we have to get to freeze plasma within the 6 hours is necessary to create fresh frozen plasma. So Sandoz actually offers FFP24. Is it equivalent to FFP in an emergency massive transfusion? I don't know. There's no literature to say whether it's equivalent or not. Some protocols throw in cryoprecipitate fibrinogen. The role of these is not clear in massive transfusion. And when do you switch from the O blood that you're transfusing back to the patient's blood type? Because usually in a massive transfusion, if you have a massive transfusion protocol, they will quickly send you a pack of O blood because it's much faster just to give O blood rather than wait for the ABO typing. At some point, do you switch? Once you have the patient's blood type, do you then switch to the patient's blood type, or do you need to carry on with the O blood because you've essentially converted the patient to O blood type after a massive transfusion? That is a question that has not been adequately answered. That said, despite all those questions that we don't have answers to, there is a problem that we are trying to solve with massive transfusion, and it does reduce mortality. Massive blood loss involves loss of red cells, as well as plasma and clotting factors, as well as platelets. So you get hypoxia from the loss of red cells, shock due to the loss of circulatory volume, and acidosis due to tissue hypoxia, as well as coagulopathy. Yes, you can get Ringer's lactate or saline, expand the volume. That doesn't solve your problem of not having adequate oxygen delivery and reversing the coagulopathy. In fact, you can worsen the situation by promoting heat loss by the volume expansion, basically shunting heat from your core to your skin. You then get a hypothermic patient, and hypothermia shuts down coagulation pathways, which worsens the coagulopathy. So the idea behind a massive transfusion protocol is put all three whole blood components back into the patient: the red cells, the platelets, and plasma, to reverse hypoxia and reverse coagulopathy. Massive transfusion protocols have been shown to reduce mortality. Depends on which study you look at, but overall, you got some studies around 20% reduction in mortality and up to 65% in some studies. What is a massive blood transfusion? It's arbitrarily defined as the replacement of the whole blood volume within 24 hours, or 50% of the patient's blood volume in 3 hours, which is a very academic definition and not particularly easy to apply at the bedside because it's more of a retrospective definition. This has also been arbitrarily defined as the blood loss of nearly 100% of blood volume within 24 hours. Also as fast bleeding. If you're losing blood 150 mils per minute, 1.5 mils per minute per kilogram over 20 minutes, which again is a bit of an academic definition, because how do you measure this at the bedside? So in terms from the sort of emergency medicine perspective, these are sort of commonly accepted triggers for massive transfusion. If you're on your third unit of emergency blood and you think you're going to need more, or if at any point you think this patient is going to need more than 3 units of emergency units, you're probably going to need to do a massive transfusion. Or if you have what's called the rabbit score, if you score 2 or more on a rabbit score. If you take your heart rate divided by your systolic blood pressure, and that gives you a value of 1 or greater, that gives you a point. If there's a pelvic fracture, it gives you a point. If you've done a fast ultrasound and that's positive, or there's penetrating trauma, and you have any 2 of these, you should probably activate your massive transfusion protocol. This is the most accurate test that has been designed for predicting the need for massive transfusion, and even this has only a sensitivity of 78%. Then what ratio are we going to give? So the US military pioneered massive transfusion, and they stuck to 1-1-1. There was one red cell unit, one frozen plasma unit with one buffy coat-derived platelet. This ends up becoming the sort of limiting factor because they have pooled platelet products being 6. So in order to maintain this ratio, you have to give 6 red cells, 6 plasmas, 6 and 6 buffy coat-derived platelet units, and that is one pooled platelet. However, in non-military settings and civilian settings, 2-1-1 has been tried with good effect. So in other words, 2 donor red cell units to 1 donor fresh frozen plasma to 1 single buffy coat-derived platelet. So in the European setting, that would be 1 pool platelet with 4 plasma units and then 8 red cells. 8 red cells, yeah. No, sorry, it's supposed to be 2. Sorry, my math is not mathing this morning. But the idea is that you can reduce the amount of red cells by half. So have instead of a 4-4-1, you can have a 2-4-1. Right, the role of routine platelet transfusion is questioned by some experts. Some units will only transfuse the patient if there's a thrombocytopenia. So less than 50, or if there's less than 100, a platelet count less than 100 for head and spine injury, because there's no clear evidence that platelet transfusion without thrombocytopenia actually does anything. So here are some examples of various transfusion protocols. As I said, there's not much standardization. You have here, we have a 10-4-2 for package 1, and then they go down to 6-4-2. This one will have a 1-to-1 ratio, but not give platelets until the next round. This one has a 2-to-1 ratio, so 5 red cell units to 2 plasmas. So what I meant to say here is that you keep the red cells, but you halve the amount of frozen plasma. Sorry about that. So here they kept, instead of having 5 red cell units and 5 plasma units, they've halved the amount of plasma. And similar story here. So the very variable massive transfusion protocols. Some of them will include cryoprecipitates or factor 7, and none has been proven to be better than any other. Right. And then adjuncts with massive transfusion, you need to warm the blood. You'll keep the patient being hypothermic, warm your fluids, warm your air, keep the patient warm, and then give calcium. And the recommended dose of giving calcium varies. You can give 1 gram of calcium per red cell unit, the so-called 1-1-1-1 ratio. So every time you give a red cell unit, give 1 gram of calcium, and then other units will give 1 gram for every 4 units. So basically every round of massive transfusion. There's no evidence to really say what is the optimal amount of calcium to give. But except that calcium should be given at some point. The reason for that is that the anticoagulant agent in the red cell units will chelate the patient's calcium. And once that calcium is iatrogenically reduced by blood transfusion, you're going to end up having a coagulopathy because calcium is important for the coagulation cascade. Manage your pH. You want to avoid acidosis with sodium bicarbonate in respiratory settings. And you can give fibrinogen, 1 unit per 10 kg, or about 10 units for adults. You can give tranexamic acid. So this, in the CRASH protocol study, was shown to be quite beneficial to give 1 gram of tranexamic acid on a cyclocapron, and then followed by 1 gram infusion. That has been shown to reduce the amount of adverse outcomes. However, some experts, when I went into literature, recommend rather just giving 2 grams IV instead push, because to maintain a 1 gram infusion over 8 hours in a massive transfusion setting is technically very challenging. The patients on anticoagulants provide reversal, and we have other agents for to maintain hemostasis, such as prothrombin complex concentrates like hemosolix complex and recombinant factor 7. So when you stop massive transfusion, You want to, or what are your targets while you're transfusing? You want to keep the patient's temperature up, pH up, calcium up, platelets up, INR less than 1.8. You're not going to normalize it because FFPs do not have a normal INR. So you keep it below 1.8, keep the PT and APT less than 1.5. And then the fibrinogen, you want to keep above 1.5, more than 2 for postpartum hemorrhage. So you're going to need to monitor the patient. And monitoring can be either through a blood gas instrument, if thromboelastography, or if you have a very good lab with very fast turnaround times, you can use your a formal lab, and you should test hourly. When you stop your massive transfusion, when you've got hemorrhage control, your patient is improving, and you think you can stop your inotropes. If you fulfill those 3 conditions, you can stop your massive transfusion protocol. So the take-home message: there's inadequate evidence and inadequate standardization of the terms and products involved in massive transfusion. So I can't give you a massive transfusion protocol. You need to develop your own individual massive transfusion protocols according to your local setup and local realities. And as you need to also correspond with your local blood bank and ask, is this protocol that I want to implement realistic? A 1-to-1 ratio is widely accepted, but as I said, the rate limiting factors that pooled products are usually only available. So you can't give one donor unit of platelets. So your ratio is going to vary between 441 to 661, depending on how many donors are donating into your pooled platelet product. Here's the cost of a massive transfusion, of 1 round of a 441 massive transfusion. Progress hasn't published their 2026 prices yet, so these are the 2025 prices. So I'm sure that the prices are going to update very soon. But if you're using leukodepleted products, which is ideal to reduce the amount of adverse transfusion reactions due to white cells, it's 46,702 Rand based on last year's prices for 1 round of a massive transfusion protocol. If you are using non-leukodepleted products, it's a little bit cheaper. So obviously this price is going to go up once the 2026 prices are out. I mentioned thromboelastography, so that's the last part of my presentation. It is technically a point of care test, although the way we've implemented in Pathcare, the instrument is in our laboratory. So it's a sort of a point of care test that's within the laboratory service rather than in the wards. It evaluates whole blood coagulation, and the way it works is that the principle of the test is that you have blood in a cup, and there's a pin that rotates through the cup. You add something to cause this blood to coagulate, and as the pin slows down because of the coagulation occurring in this cup, then you have a measure of the clot strength. What has it been shown to do? It's been shown to reduce blood product usage in surgical contexts, and this is where the evidence is. It has not been shown to reduce mortality, hasn't really been shown to be of use in the emergency unit or even during massive transfusion. Although some units do use it to guide their treatment, but there's no good scientific evidence that shows that it reduces blood product usage. There's no very good evidence beyond this to say that it reduces mortality or it's really the gold standard of monitoring whole blood coagulation. So just to bear in mind, thromboelastography, where the evidence exists, it exists for reducing blood product usage. So as that pin spins in the cup, it will gradually get resistance and slow it down, and it will slow it down as the clot forms, and then the instrument will generate trace, measuring how much resistance that pin is encountering. So initially you don't have any clot because you have to go through the initiation of clotting cascade. Then you have the clot growth, which is the equivalence of your INR and your PTT. Then you have the maximum clot, which is heavily dependent on your platelets and your fibrinogen. And then after that, there's clot degradation, fibrinolysis, which is equivalent of a deep diamond test in the lab. And then eventually the clot is completely dissolved. So it creates this trace. And then it measures numbers off the tracing. So you have the R time, which is the time to start forming the clot, typically 5 to 10 minutes. If there's a defect here, you need to get FFP to restore your coagulation factors. Once the clotting cascade is finished, next it's time for fibrinogen and platelets to form the clot. So that is measured by K time, alpha angle, and maximum amplitude. So K time and alpha angle is a bit more sensitive for fibrinogen. So in particular, if you have defects there, you would give fibrinogen. And if there's a maximum amplitude is heavily dependent on the platelets. So for a defect there, you would give platelets or desmopressin to activate the platelets. And after that, you have lysis, and it's measured at 30 minutes. And if there is excessive breakdown of the clot at lysis at 30 minutes, then you need to give fibrinolysis inhibitors such as your cyclopentone. Right, so with the Take 6 that we offer at Pathcare, we also have an additional test that measures just fibrinogen, and that just also helps you to differentiate between platelet and fibrinogen abnormalities. I'll just briefly discuss that on a later slide. Classically, you would look at the graph to decide what was the issue. That's not so important anymore because these days the instrument will give you readings and you can just look at the readings and see what's abnormal on the readings. But for the sake of completeness, here are some typical sort of graphs that you get with your normal take pattern, and then as so hyperfibrinolysis will have the increased fibrinolysis. Poor coagulation will give you this sort of picture. So if there's a little brandy tubular shape, that's a normal take tracing. If you have a very long stem, the sort of red wine glass image, then that means you need to get FFP. If you have a very thin maximum amplitude, or very poor alpha angle and K time, then you need to get cryo or platelets. Or if you have a sort of very good alpha angle and K time, but very low maximum amplitude, you get the platelets, a sort of test tube picture. An upside down martini glass represents the hyperfibrinolysis. So as I mentioned, we have the Take 6 in some of our laboratories. We still have a Take 5 in a few of our labs. And the Take 6 is a cartridge model that runs multiple Take tests simultaneously. So it is more expensive than the Take 5, but the Take 5 runs one Take test. The Take 6 runs 4 Take tests all at the same time, which is why it's about 4 times more expensive than the Take 5. It has 4 cartridges. First of all, the rapid take. This is specifically designed to get you your lysis measurement as quickly as possible, because if you go back here, the lysis measurement is only measured once the maximum amplitude is hit. So the rapid take is designed to skip all this part and go straight to maximum amplitude and then start measuring it. And lysis at 30 minutes, it takes 30 minutes after the maximum amplitude is reached. So the idea behind the rapid take, let's skip the coagulation pathway and let's just get to the lysis at 30 measurement as fast as possible by forcing very rapid coagulation of our reagents. We also derived activated clotting time value from the rapid take. The clinical value of this is still unclear. Then you have the kaolin take, which is a standard take assay, equivalent to the Take 5. Then you have the kaolin take with heparinase, which removes the influence of heparin in the sample, which is equivalent of a Take 5 run with heparinase. And then you have something that I like in particular, the fibrinogen only take, which is able to assess fibrinogen activity directly, and then you can differentiate between when you need to focus on fibrinogen and when to focus on platelets. So here's an example of some raw data that I see when I'm going through these results. I first look at the Take Rapid, and Take Rapid is specifically standardized for lysis at 30 minutes. This patient does not have hyperfibrinolysis. There's been barely any clot breakdown at 30 minutes. I then go to the Take kaolin and I look at my reaction time. My reaction time is prolonged. The question I want to answer is this due to heparin or not? I then go to the heparinase one, which removes heparin. the reaction time is still prolonged. So this is not a heparin effect. This patient would benefit from fresh frozen plasma. K time is prolonged and the alpha angle is poor and the maximum amplitude is low. Now, I want to know low platelets can also sometimes cause abnormalities in K and alpha angles. So I want to confirm in my mind, is this issue due to fibrinogen or due to platelets? I'll go to the fibrinogen tag as a very low amplitude. This is predominantly due to low fibrinogen. I need to fix this patient's fibrinogen levels first before I think of giving the patient platelets. In any case, platelets without fibrinogen is going to just be a placebo effect. So based on this tag, I would focus on giving fibrinogen and possibly an FFP. The disadvantages of the TAG is you cannot assess the contribution of the endothelium to coagulation. So if the patient got von Willebrand abnormalities, you can still give a completely normal TAG. It's insensitive to antiplatelet agents and platelet inhibition. The reason for this is that the TAG measures the physical volume of the platelets due to the cytoskeletal activity, not really platelet activation per se. So the way the fibrinogen tags works, it doesn't inactivate the platelets. It has a reagent that breaks down the platelet cytoskeleton, basically deflating them. It doesn't actually it doesn't inactivate the platelets directly because platelets during a standard tag are not activated. You're measuring platelet volume only. You cannot use it to measure aspirin. You cannot use it to measure clopidogrel. For that, you need a specialized form of TAG called the TAG platelet mapping, which is not yet available in South Africa. Standard TAG only measures platelet volume, and even if they're very inactive, you can have a normal TAG. The machine heats the sample to body temperature, so you don't know the influence of hypothermia on the hemostasis. And then pregnant women have altered hemostasis, and we are unsure what reference ranges to apply to pregnant women. Pregnant women can have a normal TAG even while they are bleeding. So for pregnant women, the treatment for postpartum hemorrhage should not be guided by a TAG. You can have inconsistent results with the TAG, especially if the hematocrit is low. For low HB, you can have hypercoagulable results even in a patient that has a coagulopathy and is bleeding. Interpretation of the TAG is not well standardized. And it's unclear if resuscitation outcomes are affected. Yes, we give fewer blood products, but do we actually save lives? The TAG does take about 30 to 60 minutes to do, and it's not been proven to be better than your empirical judgment as a clinician. If you think this patient's got coagulopathy, chances are, as an experienced clinician, you're probably as accurate as a TAG when it comes to judging what this patient needs. So there's no clear evidence to show that TAG is actually better than an experienced clinician. All right, so those are my references, and illustration sources, which I can provide on request, and that is otherwise the end of my presentation. I hope there was something useful or interesting from that.
Thank you so much. I think this was quite insightful. I thought I knew how to interpret TAG until today. Obviously, it's quite challenging, and I think that's probably the reason why we don't actually request TAG tests, because you always get stuck. Because we also don't get those data. We only get 3 readings. I think we did one yesterday. But I just got 2 questions. One is obvious, I think probably just a suggestion that, what the TAG interpretation, unfortunately, is not a theoretical kind of knowledge. It's quite kind of practical kind of experience. So perhaps what will happen then, because we have a fellow there, Dr. Como, and we have a physician that we deal in ICU, and it's quite a very important ICU kind of tool actually that can be used. Perhaps it's possible to collect quite a few kind of text that was done, and we sit and take 10-15 minutes practical, just see each person to see whether they understand. And I think obviously the more you see, the better you become. So maybe you could just do a training for that for us in the hospital, so we can do repetition until quite well. And second thing, so obviously it's about, I think you obviously clarify something. I remember when I wrote my exams in pulmonology, because critical care is part of it. And one of them is about massive transfusion protocol. And clearly, I think we didn't understand, because we always use the European protocol, which is 4-2-1. Now, would you comment regarding that? Because now we have a fellow that probably might need to write exams, and that might actually pop up. And the question that we should be confused, would the actual examiner understand that we should not be using 421, rather using the South African, which is 5, isn't it? Yeah.
Look, there's no good evidence for or against any protocol. And when I prepared this presentation, I looked for massive transfusion studies in South Africa. There are none. So, I mean, there's very little evidence to support one protocol versus the other. We might find that actually by sticking to what they are doing, we have better outcomes, we might have worse outcomes. I don't know. I don't have any scientific data. The ratios are very arbitrary, and there's very limited evidence. I suppose it's better than nothing. You have no South African data.
Yeah.
So you need to adapt something, and you need to understand what is the logic and rationale of it, and understand, with that understanding, you can apply it. But ideally, we should have some sort of monitoring or some sort of scientific trial, and just see what are the outcomes of massive transfusion, because there is no literature in South Africa on massive transfusion. All the literature is North America, Europe, Asia, nothing from Africa per se.
I've got a couple of questions. So the one is regarding the TEC and the DIC score. Is there any difference between the two? Is one better to do or not? For instance, a patient who comes in with septic shock and DIC, we normally do a DIC score. But is there any value doing a TEC, or is TEC mostly for patients before or during or after surgery where you give transfusions? And then
Well, the TEC, where the evidence supports TEC, the reason we managed to get the TEC 6 and approval of the medical aids for the TEC 6 is that it guides blood product usage. It's not been validated for diagnosis of DIC. ISTH DIC score has been validated for the diagnosis of DIC. If you decide now you need to give blood products to this DIC patient, or there's a clinical problem you want to solve, this patient's bleeding, or you want to give a blood product to control the bleeding. That's where TEC would guide you as to what is the most appropriate product. Should you give Renogen, plasma, or platelets? The TEC will help you make that decision. You might also, from your clinical sort of judgment, decide that this is what the patient needs, I'm going to give it. And the outcomes will probably be the same, except that maybe you use more blood products because you're not being as precise with your treatment. So where the TEC has been shown to be useful is in choosing blood products to give the least amount of product to the patient to give you the equivalent outcome at the end. And that's why the medical aids are willing to pay for the TEC 6, because blood products are expensive, as I showed you with the prices for the massive one round of massive transfusion. And the medical aids are willing to pay for it on the basis that if clinicians use it for that purpose, they'll save enough money on blood products to justify the cost of the TEC 6. So I hope that answers your question. It is a guide to where clinicians use it for different reasons. For example, it's the only way to diagnose hyperfibrinolysis. But where the best evidence for the usage of it is in guidance of blood product usage. It has not been validated as a diagnostic tool per se, although it can give you supported evidence. So I'm not going to say don't use it. It's there. You can do it, whatever can benefit the patient, use it. But for the IC, clinical judgment of the situation is got good sensitivity, specificity for diagnosis of DIC. And the DIC score is the only score that's been properly sort of validated to guide you in the diagnosis of DIC. But even the DIC score, if you don't, it's the way they put the caveat in the literature is that diagnosis overt DIC. So non-overt DIC might still be present, and you can still use your clinical judgment to say this is still, I think, an early DIC that maybe doesn't go into high enough in the DIC score. Other challenge with the DIC scores can be pushed up by liver disease, even without DIC. I still think it has a good negative predictive value, also like a D-dimer test. In liver disease patients, you need to have the clinical picture of DIC plus the supporting evidence of the DIC score. And it may be it will also be helpful additional information if you're sort of on the fence.
My other question is, we see a lot of patients that come in clinically stable, elder gentleman that's been feeling well with an HbA of 4.7 that you give now 4 units of blood. So would you then need to give fibrinogen and platelets? Is that not a massive transfusion?
No, so the massive transfusion is for patients that are actively pouring out blood. They're losing plasma, losing platelets. So if you're just transfusing the red cells for a stable patient that's not bleeding, he's still got his plasma, he's still going to make plasma compensate, he's still got enough platelets. The platelets will be hemodiluted out a bit, but they should be still enough. Those others cell counts are fine. So no, technically you don't need to replace plasma and platelets. So that the whole point of massive transfusion is that you're losing the stuff and now you're replacing the stuff you've lost. So if the patient just needs red cells, just do the red cells. If the patient is stable, I would suggest matching to the extended RH and Cal phenotype and requesting that on the blood form. They do that once, they test with the patient once, and afterwards they can always just give the same unit. And then at least, if you're transfusing the patient again 3 to 6 months' time, your risk of alloantibodies is going to be much less. Your risk of delayed hemolytic transfusion reaction is going to be much less. And often these are things that you don't even detect. It's just the patient keeps coming back sooner and sooner on transfusion because they develop these alloantibodies. I think that answered your question.
Thank you so much. Yeah, Kelly, quickly, one last question.
Yes, thank you for a great presentation. I just wanted to know, so for us physicians and pulmonologists, one of the complications of massive transfusion would be a trachea confusion associated with injury. So I know there's a whole range of pathophysiology that's involved in there. And I'm just wondering, do you have to be should there be a genetic defect for you to develop like something like trachea? Yeah, like,
I'm not aware.
or could it be just anyone can develop a trachea from massive transfusion?
As far as I know, anyone can, provided the immune system has been stimulated in the right way. You need to have a hyperactive immune system with migration of neutrophils to your lungs. So especially if pneumonias or pulmonary issues, you're going to have a high tissue level of neutrophils in the lungs. And then what happens is that the transfused antibodies from the donor will then can then stimulate the patient's neutrophils directly to cause a trachea. I would say it's probably more to do with the genetic predisposition of the donor than the patient, because some people are just more prone to developing these anti-neutrophil antibodies that can cause activation of neutrophils. Usually it's due to exposure, previous exposure to white blood cells from previous transfusions or from pregnancies. That's why in some settings, if you have a patient known with previous trachea, then you have to ask them specifically for male donor plasma, but even sometimes males can also develop these sort of anti-neutrophil antibodies. So, but I think it's more the genetic predisposition of the donor to develop anti-neutrophil antibodies is more important than I think the genetic status of the patient.
Thank you so much. I think we come to an end of our presentations, and join us again next week, Wednesday, 7 a.m. The presentation will be myself, and I think we'll share the link for next for obvious next week's. Dr. Okoli, are you online?
Yes, I am. Good morning, everyone. Thanks for the presentation. Great one.
Thank you. And then I think we have, Dr. Tomek has really done a lot of great presentation, been a series of presentation of blood transfusion, blood products, and all of them are available on our YouTube channel. Please go back, and I think Dr. Kelly, your question you asked is actually we have it on the YouTube, including complication of the blood transfusion, and those are hot topics in your exams that are coming. So perhaps you need to go and listen to podcasts to catch up. yeah, so we're grateful for Tomek, and obviously you guys can access him via Pathcare. We got his contact. So I want to just say thank you so much for starting the year. Sorry, we had started very slow, but we have now ongoing presentations, and then we'll further put the topics in advance. Thank you so much, everybody. And this presentation would not be possible without sponsorship of our coffee. And please, we give you the floor. Tommy, you can log out.
Right.
Yeah.
And just briefly, please put in your name and MP number in the chat quickly. If you still want, if you want to see